we basically convened a meeting that brought together civil society organizations, development partners, and government agencies to discuss this. And out of that meeting, there were key actionable points that needed to really be implemented. One of them was to have the Council of Governors that brings together all the counties to basically issue out a memo to all counties to continue with essential health services, family planning, reproductive health, and other essential health services. We found out that utilizing a media advocacy strategy basically ended up reaching quite many decision makers. And therefore, we employed the media advocacy strategy where journalists who had been trained in family planning reporting could actually give a spotlight on what's happening in the area of essential health services. And these meant that leaders will see we need to do something around essential health services. They could actually hold these leaders accountable for implementation of essential health services. This community of journalists that had been trained in family planning reporting played a very important role in highlighting some of those innovations around continuity of health services so that they can be picked up by other areas. And that scales up the aspect of innovation, also scales out continuity of services, and that becomes important. So I will say media advocacy within the pandemic was quite a model to use for advocates to engage in ways that would expand scale up activities.
When the WHO released the COVID guidelines and Kenya customized the reproductive health COVID guidelines on how to ensure that commodities reach the hard to reach persons, we were able to push the county governments to start giving commodities in phased form where they could, whereas they were giving commodities, let's say pills just once per month, they would be able to give women commodities that would last them 3 months and encourage women to switch methods if it was necessary where they could not access a certain method. So that really worked well for us in the supply chain. There was also the look at the the family planning dashboard, and looking at how our commodities moving. And it was realized between March and May that commodities had dwindled in how they were getting to the communities. And the challenge was forecasting and quantification by the HRIOs, the Health Records Information Officers at the counties. And so a lot of trainings were done by advocates, and advocates also pushed government to allow for more trainings so that they can be able to forecast for more than 6 months. Initially, they were just forecasting for 6 months. They could now forecast for 12 months and then get commodities that would last their communities for about 12 months. At the national level, we are looking at getting about 4.1 million doses of the vaccine. And the distribution plan that was launched by the president in Kenya yesterday was that they would start with frontline healthcare workers, and then they would move to schools, they would move to teachers, they would move to the elderly. And civil society organizations have not been involved in this process, but it was a good thing that the framework was released to the public. And so now the advocates have a chance to input in the framework and say exactly who should be prioritized. Of course, we look out for the healthcare workers, but we're also looking out at equitable distribution of the commodity around the country. We are encouraging the donors to continue supporting the governments, especially in ensuring that commodities and vaccines reach the most vulnerable in our communities, but at the same time ensure that the human rights of the recipient is not infringed through lack of information, because currently what we are seeing are frameworks being developed by governments and donors and WHO without the inclusion of citizens. And so we are calling upon our donors to mainstream that. And we're also calling upon governments to ensure that there's fair distribution of the commodities. There is a lot of talk about people who are able to access paid up commodities, who can go to facilities and pay up. Then they are being prioritized than people who will get the free commodities. So we want to ensure that both those who can pay and those who cannot pay have equal access to the commodities, even as they come.
Since COVID struck, we've had a couple of innovations coming in. Of course, young people, youth-led organizations working with government, that's through the Ministry of Health, to make sure that accessibility of sexual reproductive health and rights for young people is not overlooked or underlooked, and it is consistent and continued. We've had a number of innovations, technological ones, and also outside technology. Like, for example, some of the youth-led organizations started up clinics, mobile clinics, in partnership with service providing entities like Marriage Stops Uganda, Reproductive Health Uganda. That's in a case in point is UAF, the Uganda Young Adolescent Health Forum, that started a clinic to reach out to teenage pregnant girls so that they can easily access maternal services, antenatal care during COVID, and still also have access to family planning or contraceptives. In Uganda, we have on-ground team called the village health teams that usually go door to door, bringing SRHR to families, to couples. And last year, because of thorough engagement, we agreed and also debated on it that we should have young people on the village health teams, because these are it makes accessibility easier. It makes information dissemination as well easier, and accessibility. My ask to the policymakers would be to meaningfully and inclusively engage the young people, and also not to politicize policy making when it comes to sexual reproductive health and rights for adolescents and young people. Let's work together, because it's in these joint efforts that we can achieve the same goal that we have. We all have the same goal, but working in silos will not help.
The young people, together with other civil society organizations, improvise mechanisms. For example, some organizations worked with it's a company of motorcycles. It's called Safe Border, and contracted them to be able to help access delivering of contraceptives to the communities. When they established COVID-19 structures, like the National Task Force, strategically, most of us became members. And the reason for being members was to make sure that we influence and the voice of family planning champions is represented. And we've been able to influence to ensure that the strategy and the guideline for continuity of essential health services includes a package on family planning. The latest development in regard to policy and guidelines is that Uganda has developed a community engagement strategy, and that community engagement strategy again highlights some of the community structures on how family planning services, including contraceptives, will be delivered. Now, as faith-based organizations, what we did, we worked with religious leaders and gave them messages and challenges around access to contraceptives. And because religious leaders were given different media platforms to continue passing on spiritual messages, it was easier for them to pass on message. Some of you could have seen it actually trended globally, where the Archbishop of Uganda in one of the sermons openly talked about need for women to access contraceptives during COVID lockdown because the level of pregnancy and unplanned pregnancies were going high. So that was not by mistake, but as one of our family planning champions, we passed on a message, and he was able to use that platform on television to pass on the message, and many others, only that others were not recorded.